Hello, I'm Dr. Omar and welcome to OBHealthy, a Physicians Health Network. We're a group of physicians that we have two reasons that we're here. Number one, to increase the medical education of African Americans and people of African descent. Number two is we would like to encourage young Black men to go into medicine. Yes, young Black men, you can do it. You can become a doctor, and that is one thing that we are all about. We're about supporting you and getting you through and getting you interested in taking a job that has something to do with medicine. It doesn't have to be a doctor all the time, but think about medicine when you go and think about a career. Well, welcome. We're here today. We have a topic today that we're going to talk about. And it's a topic that I feel that a lot of African Americans don't like to talk about sometimes. And those are psychological problems. We want to gear ourselves towards depression and many other aspects of psychological problems that the Black community has, and treat it as a way that we can be gentle about it. And so that we can really give you some true understanding of where we are as a people as far as our psychological health. Let me just get back to where we are. We're a webinar of Black physicians, and we're here every second Saturday of the month at 1 o'clock. And we would like you to just let people know, let your family know, let your colleagues know, let people know that we're here, that you can come in and type in your medical question, and we will do the best we can to answer that question. All right. If you miss any of our webinars, definitely you can go to OBHealthy and just click on our YouTube channel. It'll be at the bottom and you'll see the symbol. And you'll get all our past webinars on our channel. Please subscribe to the channel so that we can continue to bring this to you. All righty. The most important thing that I can say today, before we start our official webinar, is that do not change any aspect of your medical care until you consult your physician. Only your doctor, truly, only your doctor can best care for you from a medical standpoint. All righty. So what I'd like to do, and doctors will be coming in, even though we have a few of us that are on vacation, we're still standing strong. So we're going to start and introduce each of us. Dr. Sprott, please, can you introduce yourself?
Yeah, I'm Kendall Sprott, board certified pediatrician, now retired. I did critical care pediatrics for 15 years in general pediatrics and inpatient pediatrics.
All right, thank you very much. Dr. Clark.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel. Glad to be here.
All righty. And Dr. Salam, introduce yourself, please.
Good afternoon, everyone. My name is Dr. Kareem Salam. I'm double boarded in general and child and adolescent psychiatry. I work in Philadelphia. I run an inpatient adolescent unit in a hospital in Northeast Philadelphia. I'm also a founding member of Global Health Psychiatry. We publish mental health literature focused on the African-American community. And I'm on the faculty of Drexel University College of Medicine, a clinical assistant professor, and delighted to be here with these brothers every month on the second Saturday for the webinar.
All right, excellent, thank you. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a subspecialty in nutrition. And I would just like to thank, and I forgot to thank OBHealthy, our parent organization, for allowing us to bring this webinar to you. I just noted that Dr. Patrick Anderson is signing in. And I'm so glad he's here with us because I know the brother is out there doing his thing. Patrick, can you unmute yourself? Let's see if we can get you. Let's see if there he is. Can you speak, Patrick? Let's see if we have your voice.
Hey guys, good to see you.
Oh, thank you for joining us, Patrick. Yes, sir, brother. Introduce yourself, Patrick. You're right on time.
All right, it's an honor to be here with my esteemed colleagues, Dr. Salam, Dr. Sprott, Dr. Bay, Dr. Clark, who was holding down the fort to help me out to do what I need to do for my family. I appreciate everyone.
Mhm.
It's Dr. Patrick Anderson. I'm a board certified GYN oncologist operating out of Newark, New Jersey at Beth Israel Medical Center. It's an honor to be here.
Hey, Patrick, the sun looks a little different in the background there.
Yeah, well, you know, I have to position myself the best way I could get the best internet, you know? I call it the call of duty. I would like to have had the ocean behind me, but you know how it is.
All right, Patrick, you sounding good to me, brother. Sounding good. All righty, so this is what we're going to do. I'm just going to step back, and because Dr. Salam, you're going to rock and roll this webinar. But let me just open it up this way. You know, we as Black people in America, and I think all over the world, we understand blues. You know, and I call it blues because we're going to start off with depression, but you know, blues is something that we've had to deal with throughout history. You know, far before slavery started, you know, we knew what blues was. So, Dr. Salam, let's talk about depression. Let's talk about where we are at this point as a community and how we can help ourselves and how we can move forward. But I think that you truly have to understand where you are before you can move forward. So can you introduce the subject for us, and let's just get a conversation going and let's see where we are. And let the audience know that please type your questions in because we would love to answer your questions. Go ahead, Dr. Salam.
All right. So just to start off, the term depression. So if you look it up in the dictionary, you might find synonyms like sadness, like Omar mentioned, Dr. Bay mentioned the blues. But when I'm referring to depression, I'm referring to a collection of symptoms, a clinical syndrome that extends beyond sadness and the blues. Now, of course, sadness and feeling low is a part of depression, but it extends beyond that. It could be associated with feelings of irritability, feelings of hopelessness, and the central features of depression are two things: feelings, a mood component, so feeling sad and blue, an equivalent to that mood component could be irritability or hopelessness. And another central feature is loss of pleasure or enjoyment in things you once found pleasurable. The medical term for that is anhedonia. And that is critically important to remember. So for example, let's say you're someone who enjoys listening to music, watching movies, playing basketball, golfing, whatever your thing is. When you're depressed, you've lost interest in that activity and it no longer makes you happy. Additionally, depression is associated with feelings of guilt, a profound sense of guilt that could be linked to hopelessness. This guilt could be so massive, it could border on being illogical. So you could feel that as a result of your depression and the guilt linked to the depression, you could feel that you're the cause of a great catastrophe like COVID-19 or world poverty or something like that. Now, that's when that guilt takes on a delusional quality. In addition to the guilt, you could have things called neurovegetative symptoms or vegetative symptoms. And these are symptoms of depression that are linked to bodily functions. So loss of appetite, or you could have increased or decreased appetite, and that could affect weight up or down. So you could have weight gain or you could have weight loss. And in youngsters, you could have a failure to achieve a normal weight compared to their peers, right? Also, the change in weight associated with depression could be linked to poor ways of coping, seeking comfort in food, particularly unhealthy foods. Another neurovegetative symptom is associated with depression is sleep. So again, you could be sleeping too much or you could be sleeping too little. The medical term for sleeping too much is hypersomnia. The medical term for disrupted sleep is insomnia. Insomnia occurs in 3 different flavors. Initial insomnia is difficulty falling asleep. Middle insomnia is disrupted sleep. So you wake up in the middle of the night and you have trouble going back to sleep. And finally, terminal insomnia is you're waking up too early. And so you may find yourself trying to get back to sleep and you're not successful, okay? Difficulty concentrating, focusing, and remembering things, okay? Also, problems with energy, flagging energy. So, and that's linked to motivation. So you lose your get up and go, your ability to roll out of bed and get on with your day. Now, I tell people there are some folks who are so burdened with depression that they may remain in their room, in bed, under the covers, shades drawn, holed up. Some folks, it's so severe, they may not get up to go to the bathroom. But when depression is that severe, one form of progress is simply rolling out of bed. That is a small victory. And of course, I'm talking about severe cases of depression. Additionally, additional symptoms of depression are depression could affect your ability to move. So that's referred to as psychomotor disturbances. And again, these are things that are experienced subjectively. So you observe them in yourself, but they are also observed by others. So folks may notice, you're not moving around that much. You're sitting still. You seem slothful. You seem like you don't have energy. Or the opposite is psychomotor agitation, where you have excessive purposeless movement, like hand wringing, maybe rubbing your skin, being restless and fidgety. So again, you have psychomotor disturbances. So we talked about sleep, interest, loss of interest, guilt, energy, concentration, changes in appetite, psychomotor disturbances. But the most concerning element of depression is suicide, the taking of one's life. And that's typically preceded by contemplating taking one's life or suicidal ideation. Interestingly enough, most completed suicides where folks actually take their lives are not preceded by failed suicide attempts, which makes suicide very difficult to predict. And suicide is a serious topic, right? It's, it could be a part of depression, right? And it's the most common reason for someone to be admitted to a psychiatric hospital or to be admitted to a general hospital for a psychiatric reason. So suicidal thoughts. And again, suicide, the common parlance or language in mental health is that typically suicide is a permanent solution to what's usually a temporary condition. So,
Could I interrupt you just for one? So you said, are they mutually exclusive? I mean, you don't have to, if you're suicidal, you're depressed, but you don't have to, it's not the extreme, and you can't predict patients who are suicidal. You don't necessarily get a signal ahead of time before they commit or they actually attempt suicide.
So folks who complete,
right,
the majority of them do not have a history of a failed attempt.
Okay.
However, there are many folks who complete suicide who have attempted. I'm just speaking of the majority. And they are mutually exclusive. So not everyone who completes suicide has a history of depression,
Okay.
right? But of course, the best predictor of current and future behavior is past behavior.
Right.
And
Excuse me. Let me interrupt you. Dr. Salam, can you bring your voice up just a little bit? For some reason, you dropped down.
okay. Let's see. How about now?
We got you.
It's about the same, but just keep your
Oh.
head pointed towards the computer and your
Okay.
computer, and hopefully we'll get a better sound.
All right. But by all means, let me know if you can't hear me. So some things that are worrisome and possible indicators of someone who is seriously contemplating suicide. So a change in someone's habits or routine, or remember I mentioned that central feature of depression, the loss of interest of what was once enjoyable. Conversation centered around death or dying. Also getting one's affairs in order. So settling debts, someone saying goodbye out of the blue for no specific reason. And that coupled with a history of depression, you have to think that this person might be at risk of suicide. So especially someone who's experiencing profound feelings of hopelessness, okay? That's something to focus on. Now, I've given you a lot of bad news about depression, but the good news is depression is a very treatable condition, okay? And so most cases of depression are actually mild to moderate. And typically mild to moderate cases of depression do not require treatment with medication. So moderate depression, folks who suffer from moderate depression, they could benefit from medication, but it's not necessary. And I'm very conservative when it comes to management of depression. So I would like to try talk therapy, very specific types of talk therapy prior to moving on to medication. Finally, before I address Dr. Anderson's question, I see he has his hand raised. The most effective treatment for depression is combination treatment. So the combination of medication management and specific types of talk therapy that we'll get into. Dr. Anderson, you have a question.
You're on mute.
Can't hear you, Pat.
You have to
I'm
unmute, Patrick.
There you go.
There you are.
Yeah, so to add to Kevin's question about suicide, depression, and whether they're mutually exclusive, one of my conundrum is the person who's depressed who's likely to commit suicide. We're often told that this is the person who is actually in a recovery phase. Can you comment on that?
Sure. So a clear example of someone who might be in the recovery phase of a mental illness and at high risk of suicide, you might think of psychosis. So for example, someone who has a psychotic condition like schizophrenia, or the first 6 months of a psychotic condition that leads to schizophrenia is called schizophreniform. And they realize the gravity of that condition, and they realize the impact that it has on their mind and their ability to test reality. That could be a very alarming and concerning situation. And once they clear and they have insight into the extent of the problem, they could be at very high risk of suicide. Another example of someone who might be at very high risk of suicide is someone whose depression is severe, and the more frequent your major depressive episodes occur, the longer they tend to last. And then it becomes more chronic and almost unremitting. And oftentimes some of these folks could view suicide as a way of escaping their unbearable suffering from which they have no reprieve.
Dr. Salam, you talked, Kevin, did you want to go?
No, you go ahead and then I'll
Yeah,
follow.
you mentioned the term suicidal ideation.
Yes.
And, you know, I'm a pediatrician. We had a number of adolescents who had some kind of what they thought was traumatic event. And thought about suicide and might have done something, but they really didn't have the intention of killing themselves. And so you know, when I think Patrick or Kevin asked the question about if you attempt suicide, do you have to be depressed or not? And I guess the answer is you don't have to, because a lot of folks do things impulsively,
Right.
and not necessarily having gone through those stages of the many of the symptoms that you talked about with depression. So could you sort of go a little bit into this suicidal ideation, especially as it might relate to adolescents who might impulsively act out?
Sure, absolutely. Excellent question, especially coming from a pediatrician. And this is the world that I live in. So suicidal ideation is basically thinking about suicide. What you want to keep your eyes on are acts of furtherance. So steps taken in the direction of suicide. Now, what I'm about to say is critically important, okay? There's a phenomenon called NSSI, non-suicidal self-injury. So you have armies of kids who use these behaviors. Common forms of non-suicidal self-injury, also known as self-injurious behavior, are cutting yourself superficially. That could be achieved with, you know, fingernails or sharp objects. So these are kids who may injure themselves. Oftentimes, it could be a cry for help. Other times, it could be a way where you could injure yourself to cause your brain to release chemicals, endogenous opioids, that in addition to fixing the pain from the cut, could actually elevate your mood, okay? So, and the adolescent brain is still under development. So brain development continues, particularly the frontal lobes that are involved in executive functioning and decision-making. So for lack of a better metaphor, the brakes in the brain, right? Those are still developing well into the 20s, okay? And so if you don't have a great set of brakes, you may engage in this kind of injurious behavior, which is not a suicide attempt. So if every young person who engaged in these behaviors, who one, thought about suicide, and two, who engaged in this non-suicidal self-injury, if you hospitalized all those kids, you would have no beds left for anyone else, okay? So what you look for in terms of a legitimate suicide attempt that's really concerning and that may require you to hospitalize a young person or contain them in a safe environment is a suicide attempt that results in some type of injury that requires medical treatment. So if someone took so many pills, they had to drink charcoal, they had to get IV fluids, their heart rhythm or the electrical activity that operates the heart has been changed because of the amount of pills, or if someone injured themselves so severely they went into unconsciousness, they may have required intubation or something like that. Those are folks who definitely need to come into the hospital. But someone who is anxious, frustrated, upset, and they may cut their skin, they may bang their head, something like that, they do not need to be hospitalized. Let me carve out one exception. Let's say someone bangs their head to the point of unconsciousness, or they fracture a bone in their face or in their head, particularly in the face. They will likely have to be hospitalized. But again, non-suicidal self-injury is very common. Also, the report of suicidal thoughts, particularly if it's impulsive, oh, I just want to kill myself, I want to die. It's important to have a dialogue with that young person to assess the seriousness. And if you feel that that exceeds your comfort zone, then you could take a young person to a crisis center. The other thing too is that could be very revealing for a young person, because you could have a conversation with them. Is this, you could essentially ring a bell that can't be unrung. And if you end up going to the hospital, not a therapist's office or a psychologist's office or psychiatrist's office, but if you go to an emergency room or crisis center, there is a risk of you being hospitalized. And there is a risk, especially if there's dangerousness involved, that you could be hospitalized against your will. And that involves taking away some of your civil rights, particularly freedom of movement. And again, in this country, that's something that's taken very, very seriously. And so it's always good to have a conversation with a young person to assess their seriousness in the wake of a threat. But as Dr. Sprott mentioned, all that impulsively reports suicidal thoughts, or all young people who engage in injurious behaviors do not necessarily want to take their lives. As a matter of fact, most of them do not.
Can we go back to just one issue? So you mentioned the definition to some degree of depression, and then you mentioned that there are different ways of treating it, and there are different grades or stages. Can you comment on, I think we're all probably walking around to some degree with mild depression to some degree, but how do you define what moderate and severe is, and what's your approach to different treatment options for each of those? And bigger picture, are there people that are more susceptible to be in those categories? Probably the more moderate and severe. Are they more susceptible, and can we do anything to identify and prevent that?
Well, excellent question. Depression among mental health conditions is quite heritable. So if you have a first-degree relative diagnosed with major depressive disorder, so a first-degree relative would be a parent, a child, or a sibling, then there's a 40% likelihood your risk of developing depression is 40%. Okay. Now, in terms of mild, moderate, and severe depression, that depends on the number of depressive episodes per year. And a depressive episode in adults is defined by 2 weeks of having at least 5 of those symptoms, and for a period of 2 years or more. So you have episodes like this that occur, that the entire episode doesn't last 2 years, but you have a history of this that extends beyond the 2-year period. And in children, these episodes occur over a 1-year period. Now, again, mild, moderate, and severe is determined by the frequency of episodes and functional impairment. So you want to look at an adult's ability to meet obligations through work, through their social relationships, and behaviors. So are you able to function socially, emotionally, behaviorally, intellectually? And same thing with children. So good measures in adults are, your occupation and your ability to manage, relationships in your home and outside of your home. With young people, school. So their ability to participate in school, meet their academic obligations, maintain their social relationships with their peers, and the like. And so that's how you break down those categories. Now, in terms of treatment, mild and moderate depression could be approached with interpersonal therapy or cognitive behavioral therapy. Now, the most well-studied treatment of depression, therapeutic treatment of depression, is cognitive.
I was going to ask you to define those.
Could you break some of that down for us? Cognitive. Break
Sure.
it down for us a little bit.
So cognitive behavioral therapy, in short, is known as CBT. And the thesis behind that is that distorted behaviors and actions are a function of distorted thoughts. Okay. And so if you could repair the thoughts, you could repair the behavior and repair the symptoms of depression. So the beauty of CBT is it's highly manualized, it's associated with homework, and it requires training of the professional. So the best practitioners of CBT are those who have the most in-depth knowledge and training, and they tend to be psychologists, okay? Ironically, the mecca of CBT is right across the river from where I live in Philadelphia. So it was initiated by a Dr. Tim Beck. He passed away within the past year or two, and he was affiliated with the University of Pennsylvania. So it's highly manualized. You know, you're making this amount of progress or not during week 1. It's associated with homework, and it's a very active form of therapy. It's different from psychoanalysis, where you're laying on someone's chaise lounge, and you're having a conversation about your internal drives and wishes and things like that. And then interpersonal therapy, the focus is more on relationships and navigating those and how that impacts mood, the impact that has on mood. Again, both these therapies are well studied, randomized, controlled, double-blinded studies that showed significant treatment effects. So I would recommend for mild to moderate depression, you start out with those therapies. Now, there's some folks who may not have a robust response to those therapies, and they may require more. And so then you have a conversation about more biologically based treatments like medication. So the most commonly prescribed medications to address depression are SSRIs, selective serotonin reuptake inhibitors. The most popular one is Prozac, fluoxetine. It's been around since the late 80s. It's also the most well-studied in children. Other examples of SSRIs are sertraline Zoloft, citalopram Celexa. I'm saying both names of each drug, escitalopram, Lexapro. And then those medications affect a brain chemical or a neurotransmitter called serotonin. You have other antidepressant medications that affect not only serotonin, but norepinephrine as well. Examples of those are venlafaxine Effexor, duloxetine, Cymbalta, or Pristiq, which is closely linked to venlafaxine. It's very similar in its structure. Now, SSRIs, as a matter of fact, any antidepressant, this is very important. No antidepressant is a happy pill. So here, take this pill and you'll be happy. Doesn't work that way. Antidepressant medication works if you take the medication once a day, every day, rain or shine, rainy mood, shiny mood, you take that pill. And your mood can gradually elevate over a period of weeks, okay? So if you're fortunate, you may have a mild elevation in mood during the first 2 weeks. You may have additional mood elevation in 4 to 6 weeks. But an adequate medication trial could take up to 8 to 12 weeks, 2 to 3 months. So again, if you take the medication and you don't experience anything, that doesn't necessarily mean the medication is ineffective. Perhaps you're not taking an adequate dose, and you've not taken it for an adequate duration.
And just a quick point, this is medication by itself, or this is medication in addition to those other therapies that you mentioned?
So the best, most effective treatment is combination treatment.
Okay.
But there's some folks who can respond to the medication without therapy. And more folks respond to combination treatment. And then there's some folks who don't require medication. Now, when we talk about medication, And these are medications that affect folks' brains and the brains of other people's children. You want to have a discussion about side effects, okay? So what you want to concern yourself with are the most common side effects and the most debilitating side effects, the ones that cause you the most trouble. So the most common side effects of SSRIs, which are the most commonly prescribed antidepressants, involve the gastrointestinal system. So the stomach, the esophagus, the small intestines, the large intestine, that the system involved with, the transport and extraction of energy from food. So the GI system. And so some of those side effects could be nausea, vomiting, diarrhea, but most commonly, the most common GI side effect is just a stomach discomfort known as dyspepsia, okay? So the most worrisome side effects are, well, a worrisome side effect of some antidepressants could be sexual dysfunction. So it could be a disruption of the orgasm. It could be a disruption of ejaculation in males. It could be, perhaps a loss of interest in having sex, more commonly known as libido, the appetite for sex. So there's that. Of course, not everyone experiences this. Some people do. And the absolutely most concerning side effects of antidepressant medication, particularly in the young. So there are some kids who could experience suicidal thoughts or who could engage in non-suicidal self-injury. So the cutting behaviors, things like that. So for example, I've cared for youngsters who I've started on an SSRI and they say, doctor, this is making me worse. They're feeling agitated. And these might have been kids who were depressed, but never suicidal. And some of these kids, if you start them on an antidepressant, they could start thinking about suicide or injuring themselves. And what you do then is you could discontinue the medication. You could try a different one. But most importantly, you want to have that conversation about side effects prior to starting the medication. That way, no one's surprised and they know to reach out to you if they experience this particular side effect.
Hey, Dr. Salam.
Hold on just for a minute, Patrick. Hold your hand. I have several questions, and Patrick, don't forget your question because we'll get back to it. But we have several questions that have come up on the board.
How about Dr. Court?
First, I would like to get Dr. Court to help me out there, Dr. Clark. Dr. Court, could you please unmute yourself, please? Can you get him to unmute and introduce himself, and then we'll go to those questions. Good afternoon, Dr. Court.
Good afternoon, my friends.
All righty, can you introduce yourself, and we're going to go to some questions.
My name is Dr. James Court. I practice in East Orange, New Jersey. My specialty is internal medicine. And forgive me for being late. I had to attend one of my patients' funeral earlier today.
All righty, thank you very much. Thank you. The first question is, and this is from Aaron, Mr. Aaron. Oh, no, sorry, Miss Aaron. Do some persons diagnosed with depression harm others, or are they just focused on themselves?
Well, listen, I'm sure you could find, exceptions to anything, but in medicine, we focus on the things that are most common, right? And, medicine involves a lot of pattern recognition, and the patterns tend to repeat themselves. So it is not common for folks who have depression to harm others. So, by the way, there's this misconception that the mentally ill are more violent and aggressive than the general population. However, if there are concerns for aggression and physical aggression towards others, it more commonly occurs in someone who may be out of touch with reality because they have psychosis. So whether it be under the influence of a substance that could cause psychosis, like PCP, angel dust, like synthetic cannabinoids that far too many young people are using. It goes by different names, wet, K2, spice, something like that. Or if someone has a primary psychotic condition like schizophrenia. Additionally, there's some mood disorders like disruptive mood dysregulation disorder that could be associated with aggression. And this condition is more commonly, it's actually by criteria, it occurs between 6 and 18-year-olds. So that could be associated with physical aggression and mood instability associated with bipolar disorder could be associated with aggression. But with typical depression, major depression, physical violence and aggression is really not a common presentation. And if you think about it, one of the defining features of depression involves energy level, right? So if you have flagging energy, aggression requires energy. So again, that's not very common. They're more at risk of, they're at a far higher risk of harming themselves than others. I believe someone with a history of a major depressive episode is 17 times more likely to take their own life than someone in the general population.
All right, we have quite a few questions coming up. We're going to do one more question, then we'll get to Dr. Patrick Anderson, and then go back to general questions after that. This is one from a good friend, actually, Andy Anderson, and it says, "Good afternoon, docs. As always, thank you for what you do." Okay, are there any known mental health screening protocols that take race into account as the risk factor in a familiar way to how we see race considered as a factor in labor and delivery and medicine?
I'm sorry, to make sure I understand the question, are there any protocols or instruments that consider race as a factor?
Right.
Especially in the labor and delivery?
No, the way similar to the way there are protocols in labor and delivery.
Sure.
For you know what I mean? And
Yes,
looking at it from an African-American perspective.
So Omar, before Dr. Salam answers that question, if I could just add a spin to it that may help him tailor that question. I think an active role of the electronic medical records is to be able to establish risk assessment as to people or patients who are at risk for certain entities. And certainly depression is one of those entities. And I think the question is saying in labor and delivery, there is a screening tool that helps identify who's at risk for certain pregnancy and labor disorders, all right, that puts someone at risk for certain abnormal or untoward outcome during pregnancy and labor. And I think what the question is saying, because I was trying to type that answer, is there an effective screening tool that we can use to identify individuals who are at risk for being depressed?
So there are definitely effective screening tools for depression. Absolutely. They've been around for a while. Beck Depression Scale, Hamilton, PHQ-9, they've been around for a while. But I think the question was, so it sounds like in labor and delivery, you have protocols to assess for peripartum depression.
Correct. Yes.
Are there protocols to assess for depression taking race into account?
Yes.
So I can't name any. However, because of where we are in this country and a light has been shown on structural and institutional racism, racial trauma, we all know it's not a new thing, but others outside of our community are developing an appreciation for this history. And of course, depression is linked, risk for depression is associated with adverse childhood experiences, ACEs. So ACEs could be being the victim of some form of discrimination, which may have placed you in an environment where you're negatively impacted by the social determinants of health. So whether it be lack of access to food, environmental injustice, so living in an area with inadequate tree cover or around a lot of asphalt. So, you're living in these heat islands. Lack of access to safe, open spaces to play, limited educational and employment opportunities. So these conversations are being held, and they're also being introduced in clinical transactions. Also, the wisest among us are asking some of these uncomfortable questions. So, for example, if you're a young African-American adolescent, it might be important to ask them about episodes of discrimination and profiling and how that impacts their self-worth and their ability to proceed through life or simply just be. So I'm unaware of any instruments where these concepts are being operationalized, but I think that is actually coming. And as I mentioned earlier, these conversations are certainly being had.
The question could go in a number of different directions, and I think that aspect that you just went into is important. But I think it needs to be taken into context, what the reality is in terms of the amount of time physicians or physician extenders or whatever you want to add onto them have time to interact with the patients. And so there are these various tools. I know that when, years and years ago, when adolescent medicine was in its infancy, we had specific questions that we needed to ask as part of the history taking that dealt with sexual activity, sexual practices, the use of possible alcohol or drug use, and then the issues of self-being in terms of, have you ever thought about suicide? Have you ever attempted suicide? You ever had these kinds of things, which were a normal part of the history. And when we were coming along, it was sort of uncomfortable because the people that were asking the questions were not so sure about their ability to get truthful answers. And it turns out that adolescents were very willing to give truthful answers, but the person who's asking the question has to have a comfort level in asking the question. And when you talk about specific issues related to sort of depression or suicide as it relates to African Americans, the majority of the practitioners that are going to be interacting with African Americans aren't going to be African Americans. Kevin asked a question, and I thought you gave a reasonable answer, Kareem, about the combination of medication and cognitive behavioral therapy. Most psychiatrists are medication managers. They're on the clock and they like to dispense medications, don't like to spend a whole lot of time or effort in the cognitive behavioral therapy. And that's more likely to occur with psychologists. And so a lot of folks don't want to be seeing two different folks for the same issue. And this whole area is very, very complex. And one of the things that you talked about was in terms of depressions, how well does the individual function? And that is, it's easy when they are not functioning at all. But there are a lot of individuals who are very significantly depressed, but put on a false front. They're able to function and it takes effort for them to put on this, what I call a false front, so that it appears that they are functioning well, and they kind of are, but they still have those same kinds of feelings that affect, and one of the things that you didn't mention is self-confidence. People tend to lose their confidence in the ability of doing things that they certainly are capable of doing and ultimately can do, but that becomes a factor. And this issue of being able to answer the questions honestly. You ask the question, well, how do you feel? Do you feel down? Do you feel this? Do you feel that? The person has to answer honestly. And at the end of the day, if the person wants to get better, they have to be honest and they have to want to get better, which means taking medication. And again, we don't know why people get depressed. And even though we studied a lot about these medicines, we don't know a whole lot about how these medicines actually work inside the brain. We talk about neurotransmitters, which transmit impulses for microseconds across cells, but we don't know what's actually going on within the cells that's causing someone to have these feelings. And so, you know, a lot of people stop taking medicines because of side effects, including, you say this, a lot of folks who have diarrhea can't take it. A lot of people have this, don't take it. Or when they feel better, they feel like they don't need to take it. And then, you know, it might have taken them 6 weeks or several months in order to have enough medication or whatever the medications do are accumulating to help you feel better. Then you feel better, you say, oh, maybe I don't need to take it anymore, because who wants to take medicines forever? Except the drug companies that's making the medications. So, you know, the issue of when you feel better, you don't want to take it, and then you slide back. You may not realize that you're sliding back and going deep, and then, you know, until something happens and you have these breaks. And so there are a lot of individuals who have these cyclical episodes of being depressed, maybe getting some treatment, getting better, not taking medication, going back, and then this vicious cycle. And it's very difficult, especially when you're talking about individuals that may not be sensitive to the African-American needs and conditions to be, you know, comfortable enough and sort of bold enough to sort of go into that and to make sure that they stay on top of it.
That is something.
Dr. Court, Dr. Salam, were you going to address that? Because I want to, Dr. Court had his hand up.
Well, no, you know, I think Kendall was making comments. Ken, did you ask me a question?
Well, I did make some questions, but you know, when you mentioned about these things that people ought to be doing in combination, the reality is I'm not sure how easy it is for individuals to get that kind of treatment, especially when the majority of the practitioners are not African-American. I mean, one of the reasons that Omar started off by saying that we need to have, you know, young Black men go into medicine. We need Black men and Black women, but certainly the number of Black men going into medicine has declined over time. And so, you know, you are an extremely rare individual who's boarded in adolescent medicine and psychiatry, but there are not many Black psychiatrists around. And again, with COVID, a lot of folks were depressed and a lot of folks were seeking help. And, you know, my ability to even to get folks that I knew of that I could count on to help in that area said that they were just booked solid and they just couldn't take on new patients.
Right.
So here, let's talk about resources. So no, well, to Kendall's point, there are significant workforce issues in medicine as it applies to folks from the African diaspora. And then it's compounded within mental health. However, things have improved and they are improving. So I think some of the most common calls that I get are, I'm looking for a therapist for my Black son or my Black daughter. So some important resources are therapy for Black girls. I forget if it's .com or .org. Therapy for Black men.org. These are things you can Google these, right? Also Psychology Today, and they have a database that includes headshots of providers, and both the therapy for Black girls and therapy for Black men, those databases are organized by zip code and by city and state. And so you could find local providers using these databases. So that's certainly a start. However, depending on the severity of the symptoms, less than ideal treatment is better than no treatment. And we have to be realistic. So because of these workforce issues, there's not a Black provider that could serve every family in need, but you could find people of color, or you could find folks who may even be white who are very experienced. But of course, the ideal would be someone who may share your cultural experience, assuming they're properly trained, because there's less of a learning curve. And also the transference, and I'll explain that, it's just easier to navigate. So transference is an unconscious phenomenon. It's basically how you feel about the person who's treating you, the therapist, the psychologist, the mental health provider, based on your lifetime experience. So you could enter the room and this therapist reminds you of a racist fourth grade teacher who was very harsh to you, and you have a negative transference towards them, and that could impact the quality of the information you reveal to them, whether or not you decide to sit in that chair. Countertransference is a similar phenomenon, but it's from the provider towards the person that they're caring for. So I could have a powerfully negative countertransference or a powerfully positive countertransference towards someone who reminds me of, you know, a long lost but dear relative or a good friend or something like that. And these dynamics are fully at play in these mental health provider patient relationships. So yes, there are those workforce issues, but there are resources as well. And the final resource is NAMI, National Alliance of Mental Illness. They have a section of their webpage devoted to mental health services for African Americans. So I would encourage folks who are seeking Black providers to start with those resources. In addition to Black Psychiatrists of America and the American Association of Black Psychologists. So there are many organizations of these professionals who are available throughout the country, and you should at least make the attempt to secure their services.
Dr. Kaur, you've been patient. Do you have a question?
Yes, I do. For Dr. Salam. Dr. Salam, in addition to spending lots of time with the patients, what little tricks do you use to get patients to open up to you, to tell their story as to why they're there, what's bothering them, what's going on in their mind? What little tricks do you use? I think
Sure.
all benefit from your expertise.
Let me give you an example. Dr. Sprott mentioned asking kids about high-risk behaviors, substance use, sexual activity, things like that. Sometimes to foster the conversation, I may ask the question in a way that assumes the young person engages in the behavior. So, you know, there are a lot of young kids who are smoking weed. So I'll say, how much weed do you smoke? And then sometimes a young person will say, well, I don't smoke weed. You know, where'd you get that from? But that could bring the temperature down in the room. Asking for the beauty of psychiatry is that if you're a trivia buff and you just want to learn things, it can really help you. So if you have an idea of an interest that someone has, you could have the conversation about the interest or just make a glancing remark. I'll give another example. I had someone who had a certain surname and they had an accent that I recognized. They had a Filipino accent. And I remember I worked with a number of Filipina nurses in the past. And so I would ask questions like, you know, what are the 3 largest cities in the Philippines? And I know there's Manila, there's Quezon City, and there are others. And so you'd be surprised if you know a fact that's important to someone, that really helps. So for example, if someone has a Caribbean accent or if someone's Puerto Rican and I mention, you know, places like Ponce or Bayamon or Mayagüez or, you know, or Kingston or so if you know something about someone that's very personal and endearing to them and you make a comment on it, that can really cause them to lower their defenses. And that's important. Establishing rapport in any branch of medicine affects the quality of the medication, the quality of the information that they give you. So, and finally, I'll take a step back. Respect, dignity, kindness, eye contact. For that brief period, the person sitting before me, they command my attention, and really trying not to be too distracted. Those are just really simple techniques, just a recognition of someone's humanity. Moreover, you can leverage the relationship you have with them as their physician. What do I mean by that? We're very blessed in that society places an elevated value on physicians. And so to get the attention of a physician who society says is important, to many people, that is important. This doctor is listening to me, they're talking to me, they're looking at me, they're treating me like a human being, and not a diagnostic label that needs to be corrected. So, human decency, dignity, kindness, and attention.
Just a quick follow-up. I'm curious. Do you have a captive audience? And what I mean by that, are the majority of the patients coming to you out of their own volition, or they're coming there because they're being referred and it's a good idea that somebody sent them there?
So to your point, again, I run a locked acute inpatient unit. So most of my patients are not involuntary. So they are there because either they sign themselves in if they're 14 or above, or their parents signed them in. And then it is a small minority of patients that have been involuntarily committed. However, what they all have in common are that they're in the hospital for pretty much one of three reasons: imminent danger to self, imminent danger to others, or they're psychotic and out of touch with reality. Now, most of the kids that I care for don't want to be in the hospital. And so that creates an appetite in them, for lack of a better term, to comply. Because, and especially in the summer, they want to be anywhere but the hospital. And most young people who come to the hospital and at the time of admission, they have a place to go back to, like a home, that kind of thing. They typically don't need to be in the hospital much longer than a week. So, and the goal of hospitalization is safety and containment, really shortly after the crisis, and then referral to a less restrictive setting, whether it be a day treatment program, also known as a partial, regular outpatient where they see a therapist once a week, or intensive outpatient where they see a therapist 2 or more times per week. And then some kids may have drug and alcohol issues, and they require an appropriate referral. Rarely am I getting kids come into the hospital for anxiety, unless it's crippling,
Right.
meaning they're so anxious they can't function, they can't leave the home.
Right.
Dr. Salam,
Yeah, Patrick, let hold on, because I want to get to you next. Let's just take our halftime break. Boy, time is going so fast. I would just like to state that and let everyone know that we're here every second Saturday on Zoom, and you can come to OBHealthy, sign in, hit the Physicians Network tab, and become part of the webinar. Type your question in, and we will definitely do our best to answer it. As I always say, do not change any aspect of your medical care before you consult your physician, because only your doctor can truly take care of your medical problem. If you want to see any of our past webinars, you can go to our website, OBHealthy, and scroll down to the YouTube. Just hit our channel marker there, and for the YouTube, and you can see any of the past webinars. I'd like to thank OBHealthy for allowing us to bring this to you. And we're going to reintroduce everybody right now. Dr. Kendall Sprock, can you reintroduce yourself?
My name is Kendall Sprout. I'm board certified pediatrician, did inpatient, general, and critical care pediatrics.
All righty. Dr. Clark, please.
Dr. Kevin Clark, good afternoon again. I'm a surgical oncologist. I work at Newark Beth Israel.
All righty. Dr. Salam.
Good afternoon, everyone. Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist. I work in the Philadelphia area. Delighted to be here.
All righty. Dr. Court, please.
Dr. James Court, internal medicine. My practice is located in East Orange, New Jersey. I visit and admit patients mainly to Newark Beth Israel Medical Center, with most of these guys on the panel.
Thank you. And Dr. Patrick Anderson.
Hi, everyone. I'm Patrick Anderson. I'm a board certified gynecologic cancer specialist. I take care of women's cancer. I'm somehow honored to be connected to this esteemed group of gentlemen here. I work primarily at Newark Beth Israel Medical Center.
All righty. And I'm Dr. Omar Bey, pulmonary critical care, subspecialty, and nutrition. And thankful to be with these brothers. All right, Dr. Patrick Anderson, you're up.
Yes, so I have a comment and then a couple of questions. And the comment is, to Dr. Salam, across the spectrum of what we do, there's this idea of creating performance improvement models. Right now, Kevin knows that I'm working on one looking at how I assess patients with cervical cancer. Am I doing the correct thing when I screen them to evaluate what mode of therapy to use? And the question I have for you is, I know record EMRs are these questions that addresses the risk of mental health, and I want to specifically address providers. Is there a performance improvement model that you may know of that specifically addresses providers to help them eliminate their own personal biases when they evaluate patients or they do risk assessment? So for example, if I see a young African-American mother who recently had a baby and I say to her, your postpartum week 12, meaning you delivered 3 months ago, are you able to go back to work? And she says no. Am I now going to look at her and say, like, really? You're young and healthy. Why aren't you going back to work? Using my own personal bias to evaluate her as to what resources I should try to make available to her.
Excellent question. There are structured instruments to assess, severity of various conditions. In terms of performance improvement measures for providers to inform their clinical decision-making, I'm sorry, none come to mind, but I work in a hospital, and when I think of performance improvement measures and quality improvement, I'm thinking of Joint Commission and things in terms of surveys. But I think the best I could offer you is, let's say someone's at risk for peripartum depression. You want to assess that, and within that structured instrument, there are questions that address level of functioning and dangerousness and elements of depression. And then maybe you could extrapolate from that. But I'm unaware of any specific measures for performance improvement that assess, I think you mentioned assess providers and their biases, yes?
Right, yes. Yeah, because my goal is always trying to figure out how can I be a better doctor tomorrow than I am today.
Sure.
And I need to be fair to everyone and not use my personal biases to, for lack of a better term, judge where one ought to be, where one ought to go, and what one ought to be doing. And as you know, I often reach out to you asking for a list of providers that I can refer patients to, because oftentimes it's not the patients, but also their families. we, and you know, Kevin encountered this a lot. We deal with young patients with a terminal illness, such as a cancer, with young children that we can see in a short period will be impacted by what's happening to a parent. So looking at that youngster sitting in the room with his or her parent, trying to figure out, how are you doing? How will this impact your performance in school, and what resources are available for intervention early on in the process?
Let me direct you to one place. The website of the American Psychiatric Association, which is very easy to remember. It's psych, P-S-Y-C-K, PSYCH.org, PSYCH.org. And they actually have a mental health task force focused on DEI, diversity, equity, and inclusion, and under that umbrella is systemic racism. So, and you would have access to this information visiting their website. And I think they might be able to provide you with more detailed information than I am right now.
And then I'm going to hog one more space. And that is, you know, when we discuss depression, we tend to discuss the middle of the road. And when things are obvious, they're obvious. One of the things that fascinated me when I did my basic psych is the concept of catatonia. And then the other extreme is manic depression. So the other end of a spectrum. So can you quickly summarize for us the concept of cyclothymic disorders, manic depressive symptoms, and catatonia?
Sure. So the old terminology for what's now known as bipolar disorder is manic depressive illness. So mania is defined by an elevation in mood that could be associated with grandiosity, an inflated sense of who you are and what you achieve, increased goal-directed activity, whether it be cleaning the house at 4 a.m, whether it be going on a spending spree that you can't afford, impulsively traveling abroad, or engaging in highly reckless behavior. So depending on the severity of the manic behaviors, hypomania, low, less intense, low-level mania versus mania, where you're really off the rails and you could go for extended periods without sleep. And then in the extreme, you could become psychotic and divorced from reality. So manic depressive illness equals bipolar disorder. Now, so you have bi, two, poles, ends, bipolar disorder. The ends are mania and depression. So by definition, in order to have bipolar disorder, lifetime, you have to have had at least one manic episode or hypomanic episode. Without those, you do not have bipolar disorder. This is an excellent question because bipolar disorder is probably the most misused term amongst the lay public. So 1 minute he's angry, the next minute he's happy. That's not bipolar disorder, that's life. We have fluctuations in mood associated with events that take place in our lives. And so that is not bipolar disorder. Cyclothymia is a milder form of bipolar disorder. So your mood elevation never reaches the point of mania. So it's low level. So if you look at elevations and dips in mood as a curve, this is mania, this is depression, this is euthymia in the middle. So for manic depressive illness or bipolar illness, the curve is really, really high, really, really low. For cyclothymia, it's around the middle. So it's mild dips and mild elevations. So that's cyclothymia. Also, you may have heard of bipolar 1 versus bipolar 2. Bipolar 1, more commonly referred to as bipolar disorder, is associated with depressive episodes, the depression I described to you at the top of the webinar, problems with sleep, energy, appetite, concentration, loss of pleasure, and depressed mood, and you have manic episodes. Bipolar 2 disorder, you have depressive episodes, but your mood elevation reaches low-level mania, also known as hypomania. And so that's the difference between bipolar 1 and bipolar 2. Catatonia is a condition associated with, it could be associated with depression, and it could be associated with psychotic illnesses like schizophrenia. Catatonia is a severe condition. It could involve something called leaden paralysis, where you basically don't move and you adopt a posture for an extended period that could lead to muscle breakdown. You're not responding to what's present in your environment. It could be associated with like almost like a woke but an unconscious state. And so it's almost like an unawareness of kind of what's happening around you. So, you know, it could lead to something called a waxy flexibility, where you're like a wax figure. Another human being could move your arm in a certain way and your arm will stay in that new position. And it can be dangerous because you're not really responding to what's in your environment. And it's important to recognize catatonia because it requires very specific treatment. Catatonia is more commonly, it's exceedingly rare, but it's more commonly treated with anxiety medications, benzodiazepines, like Ativan, like Valium, like Klonopin. And these are medications that affect the same part of the brain as alcohol. So they come with addictive potential, but they're extraordinarily useful for this rare condition called catatonia. Now, in the extreme, there are times where catatonia does not respond to benzodiazepines, and it may require a more intensive intervention, like electroconvulsive therapy. Being in a catatonic state is associated with high morbidity, severe and significant illness, and possible mortality. So you really want to extinguish or get rid of the catatonia as soon as possible. And that could require electroconvulsive therapy, formerly known as shock treatments, which, by the way, that technology, within my lifetime, ECT, electroconvulsive therapy, that technology has improved vastly within my lifetime. And that's basically inducing electrical activity in the brain, essentially causing a seizure, but under anesthesia and under carefully controlled conditions. And ECT can stop psychosis, catatonia, and also severe depression. And you would only use ECT when other forms of treatment are less successful or not successful. So you've exhausted the medications, the therapies, combination treatment, and the like. And the severity of the person's illness is really essentially, they cannot function. They can't get out of bed. They can't wash and clean themselves. And they really need this treatment to get them out of their emotional stupor, for lack of a better term.
Let me ask a question about the catatonia. Do certain antipsychotic medications cause it as well? I sort of remember years and years ago, by ICU, that we had several patients come in with catatonia. And if I'm correct, there are certain medications that can drive that as well.
So typically medications that are used to address schizophrenia, but the older medications, so also known as typical antipsychotics or neuroleptics. So like Thorazine,
right,
like Haldol, like Navain. Now, I don't want to scare people away. Remember, catatonia is an extremely rare condition, especially these days. And folks are more commonly using newer medications known as second generation or atypical antipsychotics that, you know, are put you at much less risk of developing catatonia. So you may see catatonia in someone who's had schizophrenia for decades, and they've been on an older medication that's controlled their symptoms, yet there's that risk of the catatonia.
Right. Let me introduce Dr. Aluya, just had come in. Dr. Aluya, can you unmute yourself and introduce yourself, please?
Yes, hi. Good afternoon, everybody. Sorry I came in late. I was having a little bit of problem with a network where I am. Nelson Aluya, I call myself a medical advocate and a very honored a guest to be among such esteemed colleagues and brothers in the medical field. I am presently the CMO of the Newark Community Health Centers here in Newark, New Jersey, which is a federal health qualified center and will provide health services for the common man and everybody else, as a matter of fact. So that's what I do right now.
Excellent, excellent. Thank you, Dr. Aluya. Dr. Court, you have your hand up.
Yes, I did. Dr. Salam, there's almost every day that I see patients I'm bombarded with this, or Dr. Court, I suffer from anxiety. I think it's being misused. Can you clearly define for all of us what really is anxiety?
Sure. So anxiety is excessive worry and fear that interferes with your ability to function, and it typically occurs in the absence of reasons to be worried.
But these patients are not. They don't say that. They never.
So here's the thing. What I like to do, again, to get high quality information, I don't want to test you and see if you've read the manual. I want to ask you an open-ended question, and I want you to produce the information. I want to present you with a blank sheet of paper, metaphorically, and I want you to fill that in. Tell me what's going on. So you may have someone who's really savvy, and perhaps, I don't want to get myself in trouble, but let's say they're medication seeking, okay? And, perhaps they're seeking, anxiety medications, and they have read the manual, so there's that. And of course, there are other elements to someone who engages in med-seeking behaviors. But if you're a human being and you're truly suffering from a brain disorder or mental health condition, you shouldn't have trouble describing it to me. And I'm not looking for jargon, but you know what? I don't feel right. I'm worried. I think I have some pain in my heart. It never goes away. I'm sweaty all the time. I only feel safe in my home. And I feel like a prisoner in my own home because not only am I worrying excessively, but I fear that I will encounter something outside of my home that will cause me to worry even more. So to avoid that invisible enemy, I never leave my home. Okay. Now, the other thing too is, as I mentioned with the treatment of depression, medication does not have to be the first option. So there are things like progressive muscle relaxation, deep breathing, visualization, referring someone to a therapist to address these issues versus reflexively pulling out the prescription pad. But again, if someone is struggling in their own words, they should be able to fill out that blank sheet of paper and describe their suffering to you. Now, anxiety is actually more common than depression. It's really, really common. And it largely has to do with excessive fear and worrying, and it could be associated with physical symptoms. like palpitations, like shortness of breath, like sweaty palms, and the anticipation of anxiety. And then if it's pretty consistent and independent of environment, then it's generalized. So like generalized anxiety disorder, or it could occur in waves with worry-free or anxiety-free periods between the waves. And typically the waves could be associated with a trigger, like being in a place from which escape is difficult, an elevator, an automobile, a bridge, tunnel, that kind of thing. And that's more commonly associated with panic disorder. But I would interrogate the anxiety by having them just tell you what's going on. Like that helps me to help you. If you tell them, you don't want the fancy medical terminology, right? So how we've always learned how to start open-ended and then narrow the questioning as the interaction progresses.
I wonder how many members of our panel will recall seeing patients that fits your description. You don't have to answer if you don't want to make it public. Most of the time, what you describe is not what I see at all.
Well, what are you seeing?
They just have suffer from anxiety, and basically, I think they may be medication seeking, drug seeking.
So I would just, what does that mean? And then another thing too is psychiatrists, we're probably, versus our non-psychiatric colleagues, we're probably a little more comfortable with silence and pregnant pauses. And so, you get the highest quality information from the patient or the person you're helping versus your fantasy of their suffering. It's go right to the source.
Dr. Salam, if I may
Yeah.
come in here, thank you so much for what you're doing and what you just talked about, and for Dr. Cott for bringing it up. Yes, we do see a whole lot of this, and it's a question and a comment. What's the dichotomy or cut point between panic attacks, anxiety, and eventually phobia? And if there are stages of anxiety, because I've seen people who come in, it's situational. Either they want to travel and they have anxiety, or they're going for an exam, or a boss who is just over breathing over their neck to a point where it's early morning, they're about to go to work, and when they come back from work, before they go to bed, they're having palpitations, they're having headaches, and all that. I've seen a whole lot of it. And I've seen situations where there's a threat outside, and there's some form of impending doom. Let's say, armed robbers outside, or something, really terrible going outside, and somebody just completely lost it. I mean, you can't find no reason to tell them it's okay. This is not what's happening. We will be fine. All of those, spectrum of it, I've seen, to just minor anxiety from the fact that, my paycheck didn't come on time. So there's a whole wave in all of this. How do you begin to differentiate between a panic attack, which is acute, urgent, and often objective with a reason, as compared to the anxiety and then phobia?
Good. So the first thing is to hear what the patient tells you, because you will have folks who say, I have panic attacks, and they're not panic attacks. They may actually have generalized anxiety. So a panic attack is a very specific thing. It usually lasts 15 minutes to a half hour. And a half hour, if it extends beyond a half hour, it is very likely not a panic attack. Okay, so it's a discrete episode. It could have a trigger or it could not. But again, it has a trigger. It's associated with palpitations, diaphoresis, sweating, a sense of impending doom. And typically it could have a trigger, and then it could have a tool that could be used to take it away. So whether it be hyperventilating into a brown paper bag, or closing your eyes and visualizing a pleasant scenario or a pleasant environment if you have the wherewithal to do that. But panic attacks are discrete episodes, like an episode of a television show has a beginning and an end. Same thing with a panic attack. And without intervention, it could resolve. Of course, that leads to unnecessary suffering, but it could resolve. And panic attacks are very treatable through either therapy or medication management, typically medication management, because you could, as you could easily imagine, a panic attack at work, in school, it could be really debilitating, okay? And it could lead to agoraphobia, or, fear of the marketplace, fear of going into an environment where a panic attack is more likely, okay? So folks, typically when they say anxiety, usually that means generalized anxiety. So it's a mid-level of anxiety that's constant, does not occur in waves or these discrete episodes. And then it could actually impair functioning the worse it gets, especially if it's not treated appropriately. But again, the primary difference between generalized anxiety and panic attacks are the episodic nature of panic attacks. Phobias are very well circumscribed fears of it could be a fear of reptiles, it could be a fear of flying, it could be a fear of height that causes you to avoid that experience. And some people plan their lives around these fears, but let's say you have a job that requires you to fly, you see how that could be problematic. And again, those phobias could be addressed psychologically as well. So, for example, you could use a form of exposure therapy where someone is exposed to an image of the feared object, and it's like exposure and response prevention. And so they're prevented from fleeing, escaping, or avoiding the feared object. And over time, you habituate towards that feared object to the extent that you're able to tolerate being in its presence. Now, there are folks who have overvalued ideas, or how could I say, or unrealistic fears are the wrong term. But let's say you live in an area where a horrific act of violence has been committed, and you may adopt the belief that that act, I will be the victim of similar violence, no matter what. So it's almost like it's an unrealistic fear, meaning I am definitely going to be victimized in that manner. So again, if it interferes with your ability to function and you're a prisoner in your own home, you really have to get help. And really quickly, I'm going to address a question that was in the chat about an adult who you suspect needs mental health help, and they are unwilling. One of the beauties of living in this country is that you have autonomy. So you have the power to decide, what type of help you need and when to get it, and that it can't be imposed upon you, especially something that could be as intrusive as mental health help or treatment. So in the absence of an emergency, you cannot impose mental health treatment on another adult unless they've been deemed to lack the capacity to make those decisions, like refusing treatment. But a healthy adult who's going through something, you cannot impose mental health treatment on them if they're not a danger to self, others, or psychotic. But what you could do is you can be an ally. So you could send the invitation, you could plant a seed, say, hey, and you could leverage the relationship you have with them. I know you, I love you, and something's not right. I think you should get help. If you're not willing at this time, give me a holler when you are, and I'll support you, whether that means giving them a ride, accompanying them to the first appointment. But you really want to leave them with the idea of your observations, and then along with the invitation to reach out to you when they're ready to get help. I do this when it comes to medication. So I make sure I plant the seed. So I have folks tell me all the time, nah, not interested in medication, but I will plant the seed so that, once they leave the interaction with me, they're thinking about it. And should the need arise, they reflect on that reminder, and they may be open to it at some point in the future.
Salam, thank you. Well, we have some more questions, and we're getting towards the end of the show. I want to make sure that we capture some of these questions. Can I ask a few of them?
Sure.
The first one is, does antidepressant, medication cause suicidal feelings? And this is from, actually from one of our doctor friends, Dr. Robinson.
Sure. So again, I spoke on this earlier, but there's actually a black box warning on the use of all antidepressants in adolescents, all of them, due to the development of suicidal thoughts and suicidal behaviors, parasuicidal behaviors, like thinking about suicide or engaging in self-injury. And these thoughts and behaviors can occur in kids who are depressed, who've never been suicidal. You start them on the antidepressant, a percentage of those kids could develop that. So the answer to the question is yes. Far more commonly, this occurs in adolescents and young adults.
All righty. There is another question here, and it states that I am a identical twin. My twin sister was diagnosed with schizophrenia many years ago. I, on the other hand, have never been, nor have I ever had symptoms of schizophrenia. Having been reared in the same environment, in addition to having shared the same genetic makeup, how much of the diagnosis is attributed to environmental versus genetic makeup? How do you account for the phenomenon among identical twins?
So again, there's a high concordance within identical twins of many conditions, right? But it's not 100%. So, and again, there's not a specific gene responsible for schizophrenia. There are several different genes that are associated with schizophrenic syndromes. And some of the thinking of schizophrenia is that it might be actually several disorders that commonly present with psychosis. So genetically, the questioner there, they're fortunate. I mean, again, there's not 100% concordance between identical twins in terms of what disorders you get and which ones you don't. So it is, yeah, I think that's the best I could offer, but there's no single gene, like sickle cell anemia, cystic fibrosis, those are due to single genetic mutations. But
I think
schizophrenia doesn't work that way.
if I might comment on the genetic aspect of that too, is, this individual may actually, if indeed it's genetic, may be susceptible and may carry the genetic defect, but there's a concept of penetrance, right?
Mhm.
Where an entity can exist, but the manner and the magnitude in which it's demonstrated or expressed can be so variable. So that's also one concept, and it will take just one catastrophic, one significant encounter to break this individual. So, you know, in a setting like this is where that risk assessment tool is significant. And for one to encourage this person that should they start to experience any kind of symptoms, or to put it loosely, strange behavior, to bring it to medical attention, because there could be that phenomenon of incomplete penetration.
Excellent.
Oh, excellent, excellent.
All righty.
Yeah.
There's another,
So,
go ahead,
if I
Patrick.
can just say this to Dr. Salam.
Yeah.
One forum I would really like is to have a forum with you and one of our neurology colleagues sitting across from each other, because I think there is not a battle, but some discussion to be had that help us to evaluate certain conditions. So, for example, you know, I would like for you and a neurologist to sit and talk to me about depression and certain other mental health issues that occur after someone has had a stroke or a cerebrovascular accident, because oftentimes we become so enamored by the physical defects or what we call residual effects of a stroke, that we often pay less attention. Oh, here we go. This is the closest we're going to get.
We're talking about you, doctor.
My question is answered.
He pops right out. See there, Patrick, you can't get any better than that. You can't
Can't
get
get any better than
Right,
this.
what's the question?
Omar, go ahead and
Hold
introduce Dr.
on,
Lawrence
Patrick.
Daniel.
Before we go any further, Dr. Daniels, introduce yourself, and then we're gonna get right into it, brother.
I'm so sorry. As you guys can see, I have scrubs on. I'm fresh from the hospital making here, but my name is Dr. Lawrence Daniels. I'm an adult and pediatric neurosurgeon.
All righty. Thank you. Now, Patrick, go ahead, man.
So Lawrence, you know, Dr. Salam has been doing an amazing job of talking about mental health, primarily depression, in our communities and our patient population. And I was just creating a scenario of having him and a neurologist, and I said, and you're the closest to that we're going to get today, across the table, helping us to understand some of the mental health issues associated with brain trauma, whether it's due to a cerebral vascular accident or stroke, or direct trauma that causes inhibition of certain pathways in the brain.
Yeah, you know, when you talk about things like depression, I mean, you're talking about complex neurological phenomena. They're not really located in one part of the brain, right? But there is an increased incidence of depression, especially with patients with strokes. But if you think about how life-changing a stroke is, and oftentimes we as clinicians, we get really, really focused on the physical, right? Someone can't move their legs, someone can't speak. Having an aphasia is considered one of the most devastating injuries a person can have, especially a global aphasia, because you feel so alone. But an aphasia means the inability to either produce language or understand language. And just imagine someone in a room speaking, but they can understand that they can't say what they want to say, and no one can understand them. Or imagine someone speaking to you and you not being able to comprehend what they say. Imagine how alone that is, right? So there's an emotional aspect to almost every illness we deal with. And that emotional aspect affects the physical presentation and experience of that illness, right? There are studies with patients with back pain. You know, some of the larger institutes, they have patients see psychiatrists before they have surgery for back pain, because we know that their mental health is going to affect how they interpret that pain, right? So there is a strong correlation between individuals who have either neurotrauma or neurological disorders and depression and emotional stress. Whether it's related to a damage in a part of the brain that inhibits a pathway, we don't understand the evolution of complex emotions like that as they occur from the brain well enough. But we don't need to, in order to get an explanation as to why it is that someone will undergo such a traumatic change in their life and it will affect their mental health. What we do need to do is a better job, especially with us, right? With Black people, with brown people, with underserved people, Latinos, indigenous people. The medical establishment does a terrible job seeing us as complete individuals. right? And as a result of that, we get injured and they might do an excellent job taking care of the physical, but what type of home environment are you going back into, right? You can't walk, can you get up the stairs where you're located, right? And how then not being able to do what you could do beforehand, how does that affect your entire livelihood? And then how does that play on your emotions? And sometimes because these patients can't really communicate that to us, or oftentimes the neuro ICU, the neurologist, the intensivist, we're all focused on these life-saving measures. We lose that, right? We lose that, which can significantly impact someone's outcome.
Excellent explanation,
Yeah.
Dr. Daniels, and you came in right on time, right? But
You saved him, Lawrence.
sadly,
Dr. Salam.
sadly, there's a focus on things that you can see, right? In terms of medicine. So, not everyone's depression can be seen, especially as to Dr. Sprott's point, he talked about folks with the fake facade or the mask, right? And so, but you could see the deficit secondary to a stroke. You could see the entry wound of a bullet. You can see hyperpigmentation on the neck of someone with a history of diabetes, right? But it's hard to see someone suffering, especially if emotional suffering and pain, if it's milder or it's low level. Also, we learn in mental health especially when addressing depression in hospitalized patients, you want to rule out medical causes of depression before you actually diagnose depression. So is their emotional state influenced by their vitamin D level? Whether it be hyperlipidemia, whether it be diabetes, whether it be the thyroid. So you want to rule out potential medical causes that have emotional or behavioral sequelae before you treat the depression, particularly in hospitalized patients. That's why everyone who comes in to the hospital, you order a TSH, you order a comprehensive metabolic panel. A TSH is a thyroid stimulating hormone. It's a blood test. You order a CBC with differential and other basic labs to rule out these common causes, medical conditions that could have emotional sequelae before you treat the depression.
I'll take a little twist on this one, and I'll go on another little dimension. Humanity have been here on Earth for over as man, as what we are, anthropologically, for over 80,000 years. And medicine, as we know it, in its classic form, as it is right now, is only about 2,000-3,000 years old. And even then, it's been disjointed in the concept and the translation of the knowledge as we see it. And we begin to totally understand that concept of who we are, where we are, the environmental and physical structures that affect us, and as well as affecting our emotional and mental state. On top of that, there's a spiritual component to it. And that's why psychiatry and neurology is very complex. We talked about man as 80,000 years as it is, as we are, but the brain has been developing since the concept of the Big Bang. And all that neurological components and chemical composition to get into where we are. We're just at the beginning, like they say, the nascent part of where we ought to be in the future. Who knows in another 100 years where we'll be, and how much do we understand? Because 100 years ago, we didn't understand all what we know right now. Acetylation and all those things in the brain and all that. And then getting us to understand a better aspect of the spirituality of it and how it affects us. So as technology has made it possible for us to be where we are, maybe in the near future, AI would help, leapfrog that into the future and make us understand who we are better and treat ourselves better. I often say this, it's a shame and a disgrace that the world will be deprived of the brilliance and intelligence of a certain group of people based on their race. And the knowledge and concept that were documented in Africa and all that, a whole lot of it was lost. I was not allowed to get into the mainframe of what medicine is, and even humanity is what it is right now, because of just the color of the skin. It's a shame and a huge loss to humanity for the world to do that.
I have to agree with that, Dr. Aluya. Coming back from Egypt, I just got back from a trip in Egypt, and that's a primary focus. And
listen, I view us and what we're doing here as one small step in changing the narrative.
Right.
yeah,
So especially about, Black men and our community in general, just the notion of us accepting responsibility in terms of educating our community.
mhm.
So we're doing our part. So
Yes, thank you, thank you. There's another question. Let me catch this one. What are the best ways to overcome the muscle weakness and stiffness that comes with antipsychotics? And they mentioned two of the antipsychotics. One is Depakote, and the other one is Invega Sustenna.
So for clarification purposes, Depakote is not an antipsychotic. So an antipsychotic, against psychosis, usually involves perceptual disturbances and disorganized thinking. So Invega, yes, Invega is an antipsychotic, and it's used to treat disorders like schizophrenia. And Invega Sustenna is a preparation of Invega that's injected, and it's long acting. So it's typically for folks with schizophrenia or some other conditions that have not reliably taken their pills every day. So if they take this long acting injection, it's called a long acting injectable, their symptoms could be managed and stabilized over a period of time without relying on them taking pills every day. Depakote is actually a seizure medication that has the benefit of stabilizing mood. So the muscle stiffness associated with antipsychotics, so it's important, make sure you hydrate. So you make sure you're getting enough fluids, because dehydration could put you at risk of muscle stiffness. Also, antipsychotics could be associated with certain muscle-related phenomena. So you could have pretty significant contractions of specific muscle groups called dystonia, right? So like a bad contraction of a certain muscle group. It could be the muscles of the neck, muscles involved in moving the eyeballs. In severe conditions, it could be muscles that align the spine, and it could cause a violent contraction of the back. So if the muscle stiffness is related to that, that's usually an acute phenomenon with a sudden onset, and that needs to be disrupted, which could be done with anticholinergic medicine like Cogentin or Benadryl. And so that could be very, very, very uncomfortable. So you could give Benadryl to kind of relax the muscle. And again, this is in the acute setting, right? And then you could give Cogentin to prevent that medication side effect going forward. Now,
things like physical therapy and relaxation, does it help at all, or as opposed to taking another medication?
Absolutely. However, we want to focus on acute things first.
Right.
Now, I know with Depakote could have very harsh side effects. Like it could affect your blood counts, and it could affect muscle stiffness to the extent that it could cause muscle breakdown, and those muscle breakdown products could affect the kidneys. So, and under those circumstances, you may want to consider a different medication, especially if you're using the Depakote to stabilize mood and you have a whole menu of other options. But of course, stretching, regular use of muscles through exercise, whether it be walking, just, any amount of physical activity could be very helpful in alleviating muscle stiffness, in addition to adequate hydration.
Excellent, excellent. All right. Do we have any other? I thought I saw someone with their hand up, but maybe not. All righty. There's one question, and it's a great question because I have this happen in the office quite often. Does the white coat syndrome get into issues of anxiety? Blood pressure readings is high at the doctor's office, but not otherwise. Are you familiar with that at all, Dr. Salam? Because I tell you, I get some patients coming into the office and their blood pressure is through the roof.
Yeah.
And then they state when they get home and take it, and I'll call them later, and they have a blood pressure machine at home and it's normal.
So I have an advantage in that I don't wear a white coat. And so, I don't elicit that kind of response in my patients. And then I also have the advantage of dealing with patients who are healthy by and large, adolescents, right?
Mm-hmm.
So they don't have the wear and tear on their organ systems. But again, that is a real phenomenon. And you add to that some of the cultural disparities between, the person coming in for care and the caregiver. So
Mhm.
of course that could easily occur. That could be a function of, remember I talked about transference and countertransference,
Mhm.
and you could have a powerfully negative transferential experience with a healthcare provider based on a lifetime of inadequate treatment. Or to the conversation that I had with Dr. Court, perhaps you're used to not your humanity and dignity has not been adequately recognized in a medical setting. And so you anticipate, it's a form of anticipatory anxiety and like a self-fulfilling prophecy. So I've been devalued by medical professionals in the past, and you're just another in a long line of medical professionals who will continue.
I have another question. I make rounds in the ICU every day, and some of the patients there come through, and you look at patients' histories. And unfortunately, in our community, hypertension, diabetes, heart diseases is something that is very common, but also drug abuse. And that history comes along with a lot of the problems that we see in the ICU patients. Taking drugs, overdoing drugs, drug overdose that happens so common it may be a biased sample because I'm an ICU physician. But can you address some of the things that may come along with drug abuse as far as depression and where we live, the encounters that we as Black people have to come in contact with each day just to survive, and how we can move forward as far as that's concerned? Because I don't think people truly appreciate how difficult life can be for people that are of African descent.
Sadly, drugs have been a way folks have coped, and it's been a balm to soothe pain. And most folks who are addicted to drugs, they weren't born that way, right? They didn't set out to become addicted to drugs, but it affects neural networks and brain pathways that are really resistant to treatment, or very extraordinarily difficult to treat. So in terms of, some folks use drugs the way other people might use a vacation. So a temporary escape from a painful situation that in many cases could worsen the situation. So, the best way to cure addiction is to not become addicted. But it's really an extraordinarily tough hill to climb to come off of substances. And so the best thing we could do is educate folks and intervene early, and really discourage folks from excessive engagement in drug use when they're using the gateway drugs, whether it be nicotine, alcohol, or cannabis, things that are associated with much less stigma socially. But we should really encourage folks to be extremely vigilant and aware and mindful when they're using these substances. So abstinence is ideal, but it's unrealistic. And
yeah. We're a product of our environment. And unfortunately, in our communities, that's such a common problem that sometimes that, it just relates. Dr. Aluya, you have your hand up.
Yes, I know before we close for the day, thanking each and every one of you for what you do wherever you are, and for Dr. Omar Bey for putting this together and having us here. Like you always say, Dr. Bey, one of the reasons why you're doing this is to help encourage young Black men to come into medicine. And Dr. Salam had just, so eloquently in such erudite manner, just giving us some information that we need in our community. And there are very few people like Dr. Salam. And I say that because as we see here on a daily basis, we're constantly looking for psychiatrists in our community. We don't have them. And mental health issue has exponentially increased in our community. The issue of drug, the issue of socioeconomic issues, complications, lack of employment, cost of living, all of that together has made it even worse as we come out of or still weather through COVID, and encouraging young Black men into medicine. I was reading an article that was written, I think 2021, where they had said, I think the new Journal of Medicine, and they had said the number of Black doctors hasn't really changed since the 1940s. As a matter of fact, in 1900, 1.3% of individuals who practice medicine in this country were Black. It was 1.3% of Black doctors were Black. And then in 1940, it went up to 2.8. As we speak today, it's about 5.4. And if you put that who are Black, in 1940, it was 2.9. 2018, when the last study was done, it was 2.8. So in all that 1940 to 2018, it hasn't changed. And we know that you are much likely to do better or fare better when you're taken care of by somebody who looks like you. So we come here every month to do this so that we, the parents who are out there, and to those who are working and to colleagues, we're here to help your children, mentor your children to become doctors. We're also helping you to tell your children and grandkids and everybody else who you mentor to look into medicine, because that's one space that we as Black men are disappearing from. So thank you, and I thank you all for what you do. God bless you all.
Excellent, excellent. Yeah. Is there any last words there, Dr. Salam? Thank you, Dr. Aluya. Dr. Salam. Listen,
I was just going to comment on that statistics that if the general population, which has been increasing,
Patrick. Go ahead.
I was thinking that if the general population, which is increasing, outpace the number of people going to medicine, that seemingly consistent statistic of 2.8% actually.
I think Patrick.
Oh, no, there he is. There he is. You're back, Patrick. We lost you just for a minute.
Oh, no, I was saying if the increase in our general population outpaced the number of people who are going into medicine, that data of 2.8% of physicians being of color, that we may actually be losing the number of us who are going into medicine. So, this recruitment endeavor is all the more important.
Yes, yes, I agree. Dr. Salam, I want to let you have the last few words. You have done a yeoman's job today. it is so important, the topic that you talked about, depression. I think our community is, one that is ripe for this problem, simply because the trials and tribulations that we have to go through just to get through each day. So we have to keep pounding the pavement as far as educating, because health education is everything as far as I'm concerned. If you understand your problem, if you understand your community, if you understand your heritage, if you understand, then you can deal better. But not knowing is one of the worst things that we can do. And number two, not understanding how to get help and where to go for help and who can help you and what is good help. All of that we have to educate our people. So, doctor, you've done a yeoman's job. You're gonna, let's end out on whatever you want to say about depression or psychological problems for the African American.
So, in the spirit of educating the African American community, I'm going to refer folks to Global Health Psychiatry, of which I'm a founding member. This is our first book, Mind Matters, a resource guide to psychiatry for Black communities. And we break it down. We talk about common mental health conditions. Our avatar for this book was an African American grandmother. We're not hiding behind medical jargon. Our second book was How Omari Learned to Love School Again, a story about ADHD, about a beautiful brown boy whose love of learning was affected by ADHD, and how his family, and as Dr. Aluya mentioned, the doctor who looked like him, rallied around him to support him and restore his love of learning and his superpower, which was math. And then our final book was about Omari's best friend, Bree's journey to joy, a story about childhood grief and depression. Bree lost her Nana to COVID, and it affected her mood and her superpower, which was science. And again, how her village rallied around her to support her in the wake of having lost her Nana. Mm-hmm. The children's books have parent guides embedded. And so it's a family reading experience. This is a Black-owned company established by all African-American psychiatrists. Just like Physicians Health Network, we pooled our talents and our resources to produce this product for our community. All three books are available on Amazon. And finally, to inspire the brothers to become physicians, I recommend a book that I did not write called The Pulse of Perseverance, about three brothers who had every reason to quit, and they did not quit. And all three of them are physicians at this time. One is a cardiothoracic anesthesiologist, and the other two are OBGYN surgeons. And they had every reason to quit, and they did not. And so if I can become a physician, if all of us could become physicians, and those three brothers could become physicians, so can your son, brother, nephew, and other Black men out there. So it's
just to add on to that, I was at Starbucks this morning getting my usual coffee to perk me up, and I ran into a brother that by the name of Samson Davis. And if you know the three brothers, Samson Davis.
I went to med school with them.
Oh, all righty. Well, Sam saw me in Starbucks this morning, so those brothers came through the same way. All three of them got their MDs from Rutgers. They came through Seton Hall University. And, they have a book out that I think people, anyone who has a son or a daughter that's thinking about medical school, called The Pack. And these brothers put it together. They all came from Newark, and they're all physicians, and they're doing very, very good things out in the community at this particular point. So there are a lot of us out there.
It's also a movie. It's also a movie.
Yeah. So there are a lot of us out there. Well, put it this way: there aren't many of us out there. We need more of us out there to effectively do good things in our community as far as health is concerned. Anybody else want to add to this? Because I think this is just the greatest thing in the world as far as brothers getting together and talking about what's needed, how we're going to get there, and then instituting, not just talk, but institute.
Yeah, I'll say one thing just towards the end when we talk about substance abuse in our community. I don't think it's any secret, especially amongst us who live in this skin, about how difficult it is to live into this country and this caste system where we are. And a lot of what we experience with patients, especially, back in the days when I was growing up, the crack epidemic and so forth, these are people who are self-medicating, communities full of stress and grief, being at the underbelly of a depressive system that we all still, are a part of. And so there's a certain amount of grace that I think we should approach our brothers and sisters who are suffering from, and even, individuals in the opioid crisis, who are suffering from these illnesses of substance abuse. Dr. Salam is exactly correct. They hijack the reward centers in the brains, the things that motivate human beings the most throughout nature for all 80,000 years of our existence. These medications mimic these natural substances and cause us to prioritize that substance and the feeling we get from that substance and the avoidance of a withdrawal from that substance above, all different things. Some of the initial research, Dr. Salam, I have a degree in psychology. Some of the initial research that was performed on some of these pathways, these reward pathways, were done on animals, that they would stimulate these pathways, and these animals would starve to death because they would forego food in order to continue to stimulate forego food and water in order to stimulate these pathways. That's how powerful they are. So there's a certain amount of grace we should extend to our brothers and sisters under the grip of addictions, especially since after COVID, everyone's anxieties increased, everyone's emotional stress has increased. And this is something we're going to have to grapple with, but especially us in our country, considering, how the ugliness of racism and the ugliness of this caste system we find ourselves in is rearing its head again in very real and dangerous ways. So a little bit of grace to all of us.
Excellent. Well said, well spoken. All righty. At this point, we're gonna end up at this point. Let me just say that thank you for OBHealthy for allowing us to bring this webinar each month. That's the second Saturday of each month at 1 o'clock. You just have to go to OBHealthy, sign on to the Physicians Network area and register and come in and type your medical question, and we gladly answer that question. If you've missed any of our webinars, you can go to the same website, OBHealthy, and scroll down to our YouTube. Just click on the YouTube and the channel will come up. Please subscribe so we can continue to bring this to you. It's all about caring and sharing. Let others know about it, please. Family members, church members, friends. And the most important thing that I can say, throughout the whole webinar is please do not change any aspect of your medical care until you consult your physician. All righty. And, until next month, I'm just going to say peace and thank you to each and every one of the doctors, all the brothers that come on each month. And we're going to do it again next month. All righty. So peace, everyone. Have a good month.